Good morning, Dr. Benson. Can you hear me?
Good morning. I can indeed, yes.
Thank you for joining us. I hope the weather in Belfast has not been, has been as good as it has been here. Although I think you're at the moment you're in the city hospital, are you?
Yes, that's correct.
In a room, a private room there.
Yes, in a private room, just with the gentleman that you've provided for the IT support.
Yes, now I'm told there may be a problem with that at a later stage because of the access question, which will be quickly remedied if it exists. If that happens, we'll just have to play it by ear at the time. It does mean that I should say now that if there is any break, what you mustn't do, because you're going to give evidence, is talk to anyone about the evidence you have given or you think you may yet be asked to give, whoever they are, but you can talk about anything else you like. Let me tell you who you're talking to. You're talking to a very large room here, which can, when it's full, accommodate about 200 people. It isn't full. It has 8 people in it, all of whom, apart from Ms. Fraser-Butlin, who will be asking you the questions, and myself at the moment, are wearing masks. Mary will come and ask you to take the oath in a moment or two. The other name you may hear is Shumik, who will present any documents that we invite you to comment on in the course of questioning. But the real audience are the 200 or thereabouts people who are watching remotely. It is to them, really, that you're giving your evidence. This is a public inquiry. They are the public.
Yes.
Without more ado, Mary, would you ask Dr. Benson to take the oath?
Please state your full name.
Gary Michael Benson.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Yes.
Thank you. Good morning, Dr. Benson. Can I check first that you can see and hear me?
I can indeed, yes. Thank you.
I'm going to start off by asking you some questions about your CV. You qualified and completed your medical training in 1999.
Yes, that's correct.
And you then undertook various house officer jobs between 1999 and 2003, all in Northern Ireland.
That's correct, yes.
And you then had specialist registrar training in Belfast in haematology from February 2003.
Correct, yes.
It's right, isn't it, that you spent some time at the Royal Infirmary in Edinburgh from February 2007 through to January 2008?
Yes, that's correct. As part of my... Oh, sorry. Yeah.
No, go ahead.
As part of my interest or training throughout the initial part of the specialty registrar trainings came at the time of my declaration of interest within the area of coagulation disorders. There was no full-time substantive consultant in the Northern Ireland Haemophilia Comprehensive Care Centre. So the training programme service and the training programme director then had contacts with the Royal Infirmary, largely through Dr. Anderson, who had been the consultant at one of the times as my registrar timing at the Haemophilia service. So it was set up through the trust with support financially and through NIMDA and the training programme that I would spend my final year in programme, but with specific training with regard to the coagulation disorders, which Belfast could not have provided me at that time.
And I want to come back to your time in Edinburgh in just a moment once we've sketched out your CV. You returned from Edinburgh in February 2008 to take up your consultant post in Belfast. And that post includes the role of Director of the Northern Ireland Haemophilia Comprehensive Care Centre. That's right?
Yes, the post itself is a consultant haematologist with a special interest in the disorders of coagulation. And one of the roles of that overarching post is to be the Haemophilia Service Centre Director.
You're also the Clinical Director of Blood Services within the Belfast Health and Social Care Trust.
Yes, that was a recent appointment 3 years ago that I took up that additional role for the blood sciences and laboratory and clinical haematology.
And when you became Director of the Belfast Centre, you also became a member of the UKHCDO Advisory Committee. Is that correct?
Yes, that's correct, to represent Northern Ireland on the group.
Now, before we discuss Belfast, I want to ask about two areas. Firstly, can you recall what you learnt during your medical training about the risk of viral infection via blood and blood products, particularly in relation to HIV and hepatitis C?
Yeah, so even before my medical training, being a child of the early 1980s, very much aware of blood transfusion and viral transmission risks. As an undergraduate, through training for both microbiology and virology, it was very clearly taught with regards to the HIV virus and the hepatitis viruses and the risks of blood transmission. And again, that was further augmented through my haematology specialty training. And I was very fortunate through the training to spend a 3-month allocation within the Northern Ireland Blood Transfusion Service, where quite a significant time is spent on understanding microbiological and biological screening of donated blood.
Can you recall what you were taught about the seriousness of hepatitis C as a disease?
Yeah, so it was very clearly taught with regards to its blood transmission route, as well as, although a little bit rarely, with regards to sexual transmission, the derangement of the liver function tests in the acute stage and the acute hepatitis that is witnessed, and then also the protracted and prodromal phase of, for the majority of patients, an asymptomatic carrier state, with an increased risk of liver cirrhosis and liver cancer development, and also, on occasions, liver transplantation as a means of its treatment.
Secondly, I want to ask you a little bit about your time as a specialist registrar in Edinburgh. During that time, you've mentioned that it was arranged through Dr. Anderson, but did you also work under Professor Ludlam?
Yeah, so it wasn't arranged by Dr. Anderson, and because of the contact, Dr. Anderson obviously came to Belfast from Edinburgh. So based on her history with the service, the decision with Professor McMillan as the training programme director and Professor Ludlam, and the Edinburgh Training Deanery, the transfer was done. So I was a supernumerary registrar. So that's to say I was not taking part in the Edinburgh training scheme, and I was an addition to the medical team with the limitation in my role with regard to the haemophilia service and the management and the follow-up of the patients and surgery and gaining experience both clinically as well as laboratory with regards to the service.
And did you work under Professor Ludlam during that time?
I did, yes. Professor Ludlam was one of the 2 consultants at that time.
And can you tell us anything about the approach that Professor Ludlam took towards running the department? Was it collaborative or was it a more traditional hierarchical approach that he took?
Never really thought about it. I think with regards to it, much more of there were aspects of collaborative working. There were aspects of being a senior clinician with regards to working with a junior team and directing and supporting them with regards to it. So I think that at different times, depending on the different clinics or the needs of the service, his role was somewhat different. I found him personally very supportive with regards to my interest within the specialty, and certainly that he furthered that and very kindly facilitated that with his colleagues and his laboratory team.
We've heard over the course of the inquiry a lot of evidence from different clinicians and from patients about the different approaches that doctors can take, that they can be more of the traditional approach, or they can have a different approach in relation to how they relate to patients as well. Did you observe anything in relation to how Professor Ludlam generally interacted with patients? Was he of the more old school consultant, or the more, that's very stereotypical, but of the more traditional approach or the more modern approach or more collaborative with patients?
Yeah, I wouldn't have routinely seen patients with Professor Ludlam, so I wouldn't really have an observation with regards to his ways in that way.
And were you aware of any research being carried out in Edinburgh involving patients?
No.
Now, if we look at your arrival in Belfast, when you took up your post, can you describe for us the physical facilities that the centre had at that time?
Yeah, so I was the trainee from 2003 to 2007 before I left, so I was certainly very aware of what was there at that time. As a consultant, it had not changed that much from the original service that had set up further to the amalgamation of the two haematology services between the Royal Victoria Hospital and the Belfast City Hospital, and that was just before I started as a senior house officer in haematology. So in 2008, the Haemophilia Centre was established and placed in the Bridgewater Suite, which is on C floor of the Belfast City Hospital, and that's a shared floor with clinical haematology and also the outpatient cancer services. So it's a dedicated space. It consists of, and still does today, an office which is both my office as well as a room within which I will consult with patients on a day-to-day basis. There is a treatment room which has a bed in it, so if patients were to attend during the day with a crisis or if they were going for a procedure in the hospital, they would be facilitated there and we would attend to their needs with clotting factor. If they needed to be admitted, they would be admitted from that bed to somewhere else in the hospital. Adjacent to that, there is a specialty doctor room, which our predecessor, Dr. Orla McNulty, and now Dr. Charlene Neal are based in, and they are based in that room the whole time. Again, their office, as well as their consulting room. And so sort of sweep around, there is a disabled access toilet. Next is a specialty registrar room, so we're very fortunate with the training scheme that a registrar is afforded to the haemophilia service always.
Oh, I think we've lost connection.
The vast majority will do two.
We may just have lost a little bit of the sound there. Do you want to repeat where you were? We got as far as you were very fortunate with the training scheme, registrars afford to the Haemophilia Society, and then we lost you.
Okay, sorry. And so the registrars rotate on a 3-monthly basis throughout their 5-year training, and most of them will spend at least 1 3-month period, but the majority will spend 2 3-month periods. So it's a dedicated room that they can stay in, and they get their office and consulting room. There's a phlebotomy room where the patients are attended to separately and attended to by the haemophilia nurse specialist with regards to their bloods. As they would need to do. We have a small nursing waiting room for the nurses. There's a waiting area within the centre, and a large sort of administrative room which will take the data manager, the haemophilia service secretary, as well as a receptionist. So we have a self-contained unit within a unit, and all medical records pertaining to the haemophilia, or all of the patients that are looked after at the centre, not just haemophilia, their medical records are retained within the administration room separately.
We'll come back to medical records a little later this morning. What I want to pick up now with you is some sense of the staffing that's been in place at the centre. And if we start off with when you took up post, I understand from your statement that you were a single-handed consultant with Dr. Orla McNulty as the specialist doctor.
That's correct, and Orla was regraded as an associate specialist during my time there prior to her retirement. And then there were 2 full-time clinical nurse specialists with Sister Colette McPhee and staff nurse Margaret O'Donnell. So with regard to the medical and the nursing makeup of the service in February 2008, it was a total of 4 staff. We had a secretary and receptionist and 2 biomedical scientists within our laboratory undertaking the specialty coagulation investigations, both for the patients but also for the region in Northern Ireland, and a clinical scientist, Dr. Paul Winter, responsible for the genetic screening of the patients.
So that we can get a bit more of a snapshot of how things were when you arrived, could we have a look at the 2006 UKHCDO audit? Srimik, it's WITN 3082025. we can see on the first page towards the bottom that although it says at the top it's a 2006 audit, we can see that the audit visit was actually November 2007 and the final report was submitted in September 2008. And if we then turn on to page 13, internal page 13, this is something I'm going to pick up later, but while we're in the document we'll note it. It says that the previous audit in 2003... so we've completely lost Dr. Benson.
Yes.
I wonder if we take a moment's break.
Well, we'll just take a moment to see if we get it back. I'm told there was a test conducted yesterday morning which was fine, but we were warned that there might be, because it's a Wi-Fi system that serves quite a number of appliances, that there might be an outage. We'll take a break.
Thank you.
So we have to pick up again from, you were talking about the previous audit in 2003 from the document on the screen.
Thank you, sir. We were looking at WITN 3082025, page 13. Dr. Benson, we'll come to this later. I just want to note it while we're in this document. The 2006 audit recorded a previous audit in 2003 that highlighted the need for hepatology services. This has now been addressed. As I say, we'll come back to that. But if we can carry on to page 17 in this document, under the heading of comments, it noted that there have been no meetings with trust management at BCH for more than 2 years. This must be addressed given other issues that are highlighted in this audit report. Communication between trust, clinicians and commissioners appears to be very poor. Is that something you were aware of before you arrived?
It's not something that I would have been aware of before I arrived, but it's certainly been something that is not the case. From 2008 onwards, there are regular meetings between myself and the specialty commissioners at the health board with regards to the haemophilia service budget and staffing, and also regular meetings within the haematology directorate and management structure. So I can't speak of then, but I certainly know from 2008 the lengths which we had gone to in order to engage with all the management and the commissioning group.
And in terms of the staffing, if we turn on to page 24 of the report, under the heading General Comments, there's a note that the lack of permanent centre director has had an impact on all members of the multidisciplinary team, and it goes on to describe morale as being at an all-time low. Again, is that what you found when you arrived, that morale within the staff team was very low?
I think with the arrival there was great positivity, and there was a lot of really looking forward to working together and moving forward. During my time in Edinburgh, towards the end of it, having been interviewed and successful for the post, one of the things that I had done whilst there was to really try to review the service as it had been within Belfast, and to try to focus attentions by developing specialty clinics. So For example, a general review clinic would have had patients with all of the disorders of coagulation, both bleeding and clotting, coming up to the same one. So with an aim or a goal to develop a multi-professional team, it would be very difficult to think that they would be on standby for every clinic. So one of the earlier things that were put in place before I started was to construct a dedicated haemophilia-only clinic on a Friday. And this just allowed the men with haemophilia to come up, and it was a bespoke clinic. This allowed myself and the staff to focus only on haemophilia-related needs. It allowed the laboratory to focus on the samples only coming from the men on that day. And in addition to focusing on that, we also, I was also in communication with the obstetrician. And one of the services at Edinburgh that I thought worked exceptionally well was a combined on-site obstetric high-risk clinic, which Dr. Horn had undertaken on a Friday morning. So I had been in touch with Dr. Harper, who had been the specialist with regards to bleeding disorders, and really offered, as I constructed a job plan and a job timetable for myself, to seek to put in a high-risk haematology obstetric clinic, which Dr. Harper and subsequently Dr. Hunter were both exceptionally positive towards. And that's been running, it started 6 weeks after I had started in 2008 and continues to run on a fortnightly basis for women with bleeding disorders who are pregnant and going through pregnancy as a regional service. So with regard to the development of that leading up to my post, I required the team to assist me and to listen to ideas or to concepts. The final thing that they really were very helpful to me for was the construction of a questionnaire that I had written to the patients themselves. The overriding focus that I've always had has been that the haemophilia service should be there to meet the needs of the patients themselves. And we're not there to meet our own needs or what we think that they need. It's for us to understand from them. So I'd done a questionnaire in Edinburgh and provided a stamped addressed envelope, and that was given out by the team in Belfast prior to my appointment, and the results of the questionnaire, all anonymous, were forwarded to me in Edinburgh for reading. And that was really quite telling from the patient's perspective as to their observations of care and how things had been. But in response to how to improve things or with regards to their needs, they've really constructed the last 10 years of my professional service in going through that and aiming to achieve it. And I couldn't have done that without the team and their motivation. It could be considered that having been so low for so long, as the audit would have suggested, that would have continued. But I met an exceptionally excited and motivated team who I think, as the audit alludes to, were delighted to have a new consultant, centre director and colleague to work with them, and really to highlight the good work that had been done by them, and sometimes just to acknowledge that. The other bit with regards to multi-professional team working was on a Monday morning, was just, as they had in Edinburgh at that time, was to invite all members of the team in the laboratory, the administrative staff, and clinical scientists, medical nursing, on a Monday morning together in our multi-source room, and we would discuss all patients that would come up that week, so that we were all made aware of the new patients and tests, or the reviews of patients, or to highlight patients that had perhaps phoned out of hours over the weekend or who were inpatients. And that led itself then on to a CPD session on a Thursday morning for all of the team to come together and to learn from each other. Initially at the start, mutual respect for actually what everybody's job was. And so, there's a lot of planning during my time in Edinburgh further to the successful appointment, and a lot of excitement and support for the team that were there.
You've spoken just now about a patient survey you undertook before arriving. Can you tell us what the key issues were that were raised with you by patients?
Yeah, I think that for some of them, engagement long term had been challenging. I think that with regards to emergency management or complications or challenges, they would have used the service and been very happy with the service. But I think that long-term goals, I think, weren't necessarily being followed through. Some of them would have reflected what the point of going to the clinic was. because from their perspective, they knew their haemophilia, they knew the treatment, and we provided the factor. And perhaps the lack of understanding of what long-term review would be. Home delivery was one, so up until actually autumn last year, Northern Ireland did not partake in home delivery of clotting factor concentrate. Patients would phone the haemophilia centre and their factor would be provided to them through their local hospital's blood bank for their convenience. So home delivery was an important one. And a lot of them had reflected, based on the quite recent second write-out with regards to variant CJD, and a lot had shared their feelings on that subject with regard to their upset and anger.
And we'll come back to that a little later on. We were looking at the audit report, and before we leave that document, if we can look, have it back up on the screen, should we make WITN 3082025. Just looking on page 25. And we can see in the last two paragraphs in relation to staffing, although the nurses describe the present establishment as adequate, it's noted that there's not a designated social worker or psychologist at this centre, and that tends to increase demands on the nursing team. And the lack of direction for the centre as a whole is reflected in the lack of development of nursing roles and in other roles within the multidisciplinary team. The model of care in the centre has been mainly medical and with support from the centre director and nurse managers. The haemophilia nurse specialist has the expertise to expand her role. Just in relation to the reference to the model of care being mainly medical, what was meant by that? What did you understand to be being addressed there?
Yeah. Probably initially in reading it, it may be the authors of the report may have a better understanding of what they were meaning really by describing the centre like that. From my perspective, I'm not entirely sure what they may well have meant. I can have some conjecture with the meaning of it. I certainly think that from my appointment, the multidisciplinary team had been grown and has been developed, and the roles have been grown with that for everybody involved to complement the needs of patients. But
one reading of it might be that the care is very consultant-centric, with others providing support, but that the previous consultant or the senior doctor at the centre really was the central point of how care was provided. If that would that be something that the staff would have recognised before your arrival in the centre, that it was a very consultant-centric approach?
Before my arrival, there was no consultant.
But historically?
Well, from Dr. Anderson's retirement and leaving the centre to my appointment over the 4 years, the service was managed by an acting consultant with regards to the oversight of it. I'm not sure what their medical input or reviewing of patients was going to be. So with regards to senior medical, I don't know what that role would be.
Did the staff, when you arrived, did the staff ever reflect with you of how the centre had been run historically, perhaps under in Dr. Main's time, of how the centre was structured and run?
Not particularly. I think that there were some reflections with regards to physiotherapy service, which had been provided at a time in the Royal Victoria Hospital through Lynn Crockard, and a lot of the patients had remembered her very fondly with regards to that at the time of the Royal, but that hadn't transferred across to the City Hospital site. So I think with regards to allied healthcare professionals, I think that that's probably the only one that would certainly stand out as part of their reflections.
In terms of staffing, if we then go on to the 2009 audit, it's WITN 3082026. Again, we can see that the audit visit was actually in January 2010. That's at the bottom of the page. And then if we carry on to page 22, and towards the bottom of the page, paragraph 9.3, we can see the issues that were identified during the audit meeting. First of all, the need to give consideration to establishing a second consultant post. And then if we go over the page, Shumik, thank you. The first two bullet points address Dr. McNulty and the banding, the grading of the Nurse McAfee. And if we carry on further down, there are 2 points. It's recommended that social work time is clearly dedicated to haemophilia rather than existing arrangements of cover. And the next bullet point addressing the need for a data manager. Was that an accurate reflection of what the key needs of the service at that time were?
Yes, I think looking at the Haemophilia Alliance or the service specification, if we were to call it that with regards to Haemophilia Comprehensive Care Centre, they're often volunteered as key members of staff. With regards to factor allocation and tracking patients and volume that they got and their follow-up, that was something that my secretary had done, and I had continued that with regards to spreadsheets, and that was used really very helpfully to inform commissioning with regards to the use of factor and where it was going and what it was being used for. I think with regards, so I think a lot of the roles were being done and were being done as part of the medical and the nursing staff's role. Since that, as you are aware, data manager funding had been provided and had been recruited to a dedicated social worker rather than just access to the haematology social worker, which was an invaluable service whenever it was called on. But we have a dedicated social worker for haemophilia, both adults and children, and that post was agreed. We did have funding and a post holder for the second coagulation consultant as and when an interested person was able to declare that. Dr. Chris McCauley came into post, and after 2.5 years he resigned and has moved on to another haematology service. His post has been re-advertised, and we had 2 applicants, both of a very high calibre, and that was supported by the Trust and the Specialty Commissioning Group to appoint both candidates. So over the next few months, the consultant workload in Northern Ireland Haemophilia Centre for the first time ever will be 3 whole-time equivalent dedicated consultants. With regard to the out-of-hours cover that Dr. Wild was reflecting on in the audit, a lot of that would have fallen to myself, that whilst my clinical colleagues who covered the leukemia bone marrow transplant team would have also managed the inpatients for haemophilia, I was very happy and content to be second on call, that if there were any specific issues that ever arose and they wished to speak with me, that I was happy to do that, and they did.
So in terms of the staffing position now, you've noted the data manager, the social worker, and 2 further consultants who will be joining soon. In terms of the nursing staff, what's the position with that now?
We have 4 nurses. So we have Sister Helen Manson as Senior Clinical Nurse Specialist, Kirsty McMurray, we have Jackie, and we also have Christine. So we have 4 haemophilia nurse specialists working along with us. We have a dedicated haemophilia physiotherapist, and we also have funding for a haemophilia physiotherapy assistant, as well as we also have a full-time haemophilia dedicated occupational therapist. We got additional funding with regards to a second clinical scientist to work alongside the then single post holder, and we are currently seeking and support in line with the new coagulation factors to support our laboratory staff with an additional 2 biomedical scientists to go in.
In your statement, you say that you previously could refer patients to the psychology department if there was a need for increased therapeutic support. But until recently, that wasn't a dedicated service. Is that right?
No, exactly. So as with regards to any patient in any hospital, there was open access with regards to the adult psychology service. So with regards to specific trained counselling within psychology, that was there and patients were referred on. But counselling also took place informally by the medical and the nursing team with regards to talking to patients. We're not just there to ask them about their bleeds and how much factor they've taken since the last time we're there, but really to reflect with them during the period of time between their 2 hospital visits and how things were going for them, both in life and relationships and with regards to work. And it's one of the bits of the post that I use the word love. I think it may be a little bit strong, but just sitting down and just having a chat with people and just seeing how they're going and how can we help them in any particular way. And because of those chats, then that's where the whole team has come out of. Because from that, then how can we best meet those specific needs? So I think counselling is not just as a role for specially trained people, but I think it's just giving people time and not being rushed at clinics. So we lengthened hospital appointments with regards to outpatients to make sure that it was more than that. So part of that feedback of patients through that original questionnaire that I had done was really just that they weren't quite sure the purpose of coming up or anything like that. So I think building that in has certainly helped engaging with our population. The do not attend rate at the clinic has certainly been reduced by altering the model and how we deliver our care.
But in terms of formal therapeutic intervention with a trained psychologist, that wasn't embedded as part of the multidisciplinary team until very recently.
Yes, so with regards to just before the advent of the blood inquiry, whenever we were aware of it, I had advocated on several occasions with regards to that. Part of our social worker appointment, again, was being very minded towards a psychosocial training that they would have already had in place, and that we were able to avail of that background specialty training that they had already had too. We now have an appointed whole-time equivalent clinical psychologist for the service, and the trust have gone out to make that a permanent post, rather than a temporary one for the duration of the inquiry.
Just before we look at that, can you help us with this? Between your arrival in 2008 and this dedicated service that's been established more recently, I think you just said that you had sought a more dedicated psychology service in addition to your social work provision. Is that right?
Yeah, at all times with regards to the outcome that comes from any of the audits, they're shared with the trust and they're shared with our specialty commissioners with regards to outcomes and what can be achieved and what may be realistic or how we can go. So it's been very clear with regards to the need for that. I think that at the time, with regards to our social worker appointment, we were very much minded of psychology support. And I interviewed over 3 days for our social worker. And one of the key components of that was to ensure that there was a psychological background or psychosocial training that they had and they had experience of.
Do you know why a dedicated psychologist hasn't been appointed previously?
No.
You've just said that since the start of the inquiry that there has been a dedicated psychology service. Can you tell us a little bit more about what that service consists of? How many days, a week or month it's available? Yeah,
and I think it's quite variable. And it can be something that can be undertaken depending on what the patient's specific needs are. It has varied a little bit during COVID with regards to availability at weekends as opposed to during the week to reflect the working pattern of our psychologist. Patients' access can do so directly, either via the social worker or myself, and patients are put in direct contact with the psychologist. And appointments are provided. They can be remote through Microsoft Teams or Zoom, or initially prior to the COVID pandemic, they had been face-to-face. With regards to the number of patients and the frequency of sessions that have been provided, I'm not privy to the discussions or anything else that goes on out with being assured that an individual has kept the appointment that we have referred them to and that they are being followed up. So we do get informal feedback from the patients themselves whenever they attend for their haemophilia review, and they do share the fact that they are attending and how they are finding that.
And who can access the service? Is it only patients of the centre, or can those who are affected also access the service?
Yeah, so it's designed as an open access with regards to anybody who feels as an infected or affected individual. I think that in some circumstances it can be difficult for us, depending on if there are any other family members who are actually still under the care of the service, in order to ensure that we are 100% able to provide that. But at any time, if a patient or they volunteer their relative is struggling particularly, then we are able to intervene and to offer the service. Posters are placed up in our waiting room in our Altnagelvin clinic, which is a satellite service which we had started several years ago to meet the needs of our patients in the northwest of Northern Ireland. Again, the information is provided there, and a specific leaflet has been designed and drafted by the psychologist and the trust with regards to signposting, not just to the trust service in case patients feel that they don't wish to avail of that, but also through the Red Cross and through the inquiry site itself.
But if an affected person no longer has any contact with the centre, for example, if their relative has sadly died, would they be able to access the psychology service, or is that not possible for them?
No, it's a fully open access service. There's no restriction at all. More than happy to take any contact from anybody who has been touched at all by it. And there's no need that you just have to be a patient in order to access.
And are you ever told about what's discussed in those psychology sessions, or are the sessions very strictly confidential?
Well, I think it's entirely confidential. I think there's a professional code by which that you would work with. There's absolutely nothing that ever gets discussed with me. We have had feedback through our continual professional development meetings, and our psychologist has presented to the rest of the team with regards to techniques or things to help to support patients, rather than simply signposting how can we deal with events or crises as and when they arise, and they're being discussed with us. So being very helpful for those sorts of things, but anything that does get discussed remains there.
And do you have any sense of how much uptake there's been for the service?
I think with regards to the referrals that have gone through, I think with fair 90-95% of patients have attended for at least one session. Our psychologist will be able to give you the more accurate figures with regards to those who have fully engaged, but I would be able to confirm that I do receive a letter back to say that contact was made and that sessions and goals have been set and are underway.
If we can move on to the broader questions of management within the centre. The centre is the comprehensive care centre for the whole of Northern Ireland.
For adults only.
For adults. And from your statement, it's clear that the team will also provide advice to local hospitals where that's required. Is that right?
That's correct, yes.
Could you just clarify then whether all patients with bleeding disorders are registered at the Belfast Centre, or whether there is some element of being registered at local hospitals as well, and how does that work?
Yeah, so all patients are registered at the Belfast Centre. So all patients from the age of 14 can transition from the paediatric service, so anytime, any age from 14 to 16, based on the definition of a child at our paediatric service. So from that age, they will come across and they are all registered here within Belfast. From our perspective, we do undertake a satellite clinic in Altnagelvin Hospital in the northwest, and we undertake that and have undertaken it on average alternate monthly. However, based on the current COVID pandemic, that has not been possible, but we have engaged with those patients remotely using Microsoft Teams consultation. But those patients remain registered in Belfast.
We're stuck again, I'm
We're
afraid.
stuck again.
Myself will travel up there
No,
to see.
Sorry,
I think we just lost you for a moment or two. You were telling us about Oshna Galvin and the arrangements now happening. The last words we have are that those patients remotely using Microsoft Teams consultation, those patients remain registered in Belfast. Then we had a freeze on the transmission.
Okay.
So if you can pick us up from that point.
Yeah. So during non-COVID time, whenever the clinic happened, our entire team travelled up together. So myself, the nurse, occupational therapist, physiotherapist, and social worker would attend to the patients locally within their own hospital, but they were not registered there. So we would avail of the services, take their blood, do our assessments, have their medical records with us, and then they would return back to Belfast.
Now, you've mentioned there that the transition from paediatric to adult care takes place from between 14 and 16 years old. Why is that?
Yeah.
Why is it at 14 to 16?
Yeah, there may be a lot of questions with regards to Northern Ireland's ways that will have a lot of why, and I will perhaps struggle to explain it. But our paediatric hospital and its accident emergency department does not take children beyond their 13th birthday. So in emergencies, then those would be transferred over to the adult emergency department. So working along with the paediatric team, generally we are content to transition from the age of 14. Most will come age 15, 16 and transfer across.
And can you tell us a little bit about how you organise the transition of care between the paediatric team and your team?
Yeah, so it's a very fluid sort of shared care type basis. It's sort of reflected more in the current West Midlands quality review of the service, where transition was specifically reviewed. And the team had worked quite extensively on that. I think some of the UK may use the system Ready, Steady, Go to try to prepare the young man and also prepare parents. Sometimes it can be as distressing to the parent leaving the paediatric service as it is to the child. So it's preparing them, setting their goals, what do they want to see or achieve, and then to come across and then to understand how services are slightly different. A lot of the young men and young women find it a little bit more unusual that they're being spoken to rather than their parents. So they're usually doing their best to try to get me to look at their mum or dad in the room rather than having a chat with them. And so that would be an open thing with regards to their birthdays. We don't have a set time of the year where we would do that officially. In the past couple of years, whenever Dr. Macaulay was working alongside ourselves and the team, we would have supported Dr. McCartney at that time whenever she was a single-handed paediatric haematologist. And that was certainly very rewarding from our perspective and our team to be able to at least meet the children at a younger stage so they can become familiar and the parents become familiar. But as I've gone on through the service now, almost 13 years as the consultant in charge, it's the rewarding nature of seeing the mums who are carriers and their sons who have been born with haemophilia in the paediatric service and watching them come across to ourselves.
And in terms of out-of-hours care, what was the position when you first took up your post in 2008?
So the haematology out of hours service back in 2008 ran along the lines of two consultants on call. One consultant team were specialist interests with regards to leukemia, bone marrow transplantation, and that is where I was slotted in with regards to haemophilia. In essence, that team was really the historical Royal Victoria Hospital haematology team. And that was made up with Professor McMillan and Frank Jones, both of whom had prior experience and knowledge in managing haemophilia during their time as consultants at the Royal Victoria Hospital before they came across. The other haematology team then would be sort of classified as the lymphoma and myeloproliferative team. So out of hours, if there were any issues with regards to the haemophilia patients or patients under my care, that would have been discussed with that team on call with leukemia and myself. And there was a potential of a 1 in 3, 1 in 4, that I would have been the consultant on call for that weekend. We would have started at 9 a.m. on a Monday and finished at 9 a.m. the following Monday. If any of the nature of anything that came up would have gone on to the consultant, they would have wished for me to have a specialist input, then I would have been phoned directly and happy to be so as second on call.
But in terms of how the patients accessed out-of-hours care, how did that work?
Yes, sorry, apologies. That's too much about it. So from the patients, after 5 o'clock, there was a helpline number, and the patients would phone the helpline in Belfast, and that was staffed by a nurse specialist who would redirect the call and the message to the on-call haematology specialty registrar, who would have attended to the call and given advice and discussed it with the consultant. If the patient's required to be admitted or to be assessed, that would have been targeted initially through the Belfast City Hospital Emergency Department, and that has been closed, and it's now being redirected through the Royal Victoria Hospital Emergency Department. That allowed us to have factor ordered and on standby in the emergency department, and where possible, the registrar would attend there. Alternatively, Altmegelvin Hospital, for those patients who are a little bit further away, equally we would have the discussion with the emergency department there. Emergency stock of clotting factor sits in Altmegelvin Blood Bank, and again we can have that ordered and on standby and direct the emergency team with regards to the care and the throughput of the patient whenever they arrive. All helpline calls are discussed the next morning with the team, and they are followed up appropriately, as to on a Monday morning do we follow up all of the out-of-hour contacts over the weekend.
And is that the same system that's applied now?
Yes, the same system is applied now. The number of consultants with regards to on-call, instead of 2 teams, it is just done as a single consultant on-call. And I remain second on-call for all of my colleagues, and we have a WhatsApp group whereby it's an easier way to contact me as and when or should I be required out of hours or at the weekend.
And in terms of routine management of patients at the centre, how's that organised? How often will you see patients?
Yeah, so with regards to patients, we look after many bleeding disorders. So if we look after and discuss those with Haemophilia A and Haemophilia B first. So we do an all-day Friday clinic. It's generally concentrated to the first Friday of every month. And this is largely done as a bit of a round robin, not quite speed dating, but there are different stations that the patients will go around. They will all be seen by a doctor, either myself, the specialty doctor, or the registrar. They'll also be assessed and reviewed by our nursing team, who will undertake their nursing needs assessment and routine blood check and screen. Our physiotherapist is on site, our social worker is on site, as too is our occupational therapist. And should the patient's needs be such, they can be addressed by any member of the allied healthcare professionals that we have available to them.
And how often will a patient come in for that review?
So with regards to the expectation of patients with severe Haemophilia A, or severe Haemophilia B, the expectation is they're invited on a 6-monthly basis to attend the hospital for their review, and they get their joint scores done at least annually with regard to their physiotherapy or their occupational therapy assessment. Moderate haemophilia, largely a significant proportion of our patients with moderate haemophilia are on routine prophylaxis, and as such we would view them as having the same review process of 6 monthly. Our patients with mild haemophilia, we have trialled and undertaken and presented the use of a telephone virtual review service for those patients, largely because they actually carried the largest do not attend rate at our outpatient service whenever I started. So what we had done was to engage with them and did a working day and provided a lunch and a discussion as to how we could improve things for them. So initially it would have been a phone call once a year, and then the following year they would have a face-to-face consultation. Again at the same Friday clinic, and again with the same access to all of the other services. Our patients with von Willebrand's disease have a similar service set for the 3rd Wednesday of the month, whereby the whole team, as I previously described for haemophilia, are there for those patients with von Willebrand's disease, and it would follow the same pattern. Patients with type 3 von Willebrand's disease, which is the rarest, but perhaps the one that bleeds the most significantly, within our adult population, we have 3 patients. We would review them on a 6-monthly basis, but the vast majority of other patients with von Willebrand's disease will be reviewed annually, or depending on their bleeding challenges that they've faced, up to 6 months.
In your statement, you've also talked about family support days that the centre has organised over the years. Can you tell us a little bit about those?
Yeah, so it started quite soon after I'd started. The Haemophilia Society itself within Northern Ireland had not had a strong presence. So with regard to the Haemophilia Centre's role, I did feel that there was a lot of feedback coming back from patients going, in their own particular way going, what about such and such, and I haven't seen them in a while, and what's going on? And some of that was addressed by doing the specialty-specific clinics. So it was always nice to see some of the men bumping into boys that they would have sat beside in a pediatric ward many years ago, and to see them catch up. So we had initially been approached by the Roald Dahl Foundation for the first family day, which was amazing, and that we had written out to all patients, both adults as well as the pediatric service, and invited the patients up, and the Roald Dahl Foundation had covered that day for us, and we had run a small educational discussion that I had led in one of the halls of the Folk and Transport Museum for the parents to come, and there were various other activities, and there was a barbecue at the end of the day for them. It was very successful, and further to that then we'd organised 2 further educational days by the centre staff themselves, one in the Ulster Museum at a dinosaur exhibition, and a very nice dinner that night, and then more laterally at the Titanic Museum in Belfast, we had organised another educational day to facilitate the families to look at that new museum in Belfast. Since then, laterally, there have not been that many. Haemophilia NI itself has been founded by our patient group, and they have organised, and we have fully supported their own family days.
If we can now just move on to look at some figures. You've said in your statement that in 2008 there were 292 patients with bleeding disorders registered with the Belfast Centre. 41 of those were people with haemophilia A and B, and 1 was someone with von Willebrand's. Is that right?
So the classification of the smaller numbers will reflect the more severe bleeding phenotypes. So it's not all haemophilia A being 41, that would be the severe subtype.
Jimmy, could we turn up WITN 3082028, which is the audit that was undertaken in October 2019? And if we turn to page 7, there's a table in the middle of the page giving the number of patients registered at the centre, 58 with severe haemophilia A, 16 with moderate haemophilia A, 109 with mild, and then we see the figures for haemophilia B, 5 people with severe haemophilia B, 2 with moderate, 10 with mild, and then 100 with von Willebrand's. In your statement, Dr. Benson, you've given some slightly different figures. You've given a figure of a total of 596 people with bleeding disorders registered with the centre, which is rather more than we see in the audit. Yes,
so
go
with
ahead.
our current data manager, we have undertaken a review with regards to changes in classifications, particularly with regards to female carriers who are themselves affected. And whenever they have been entered in and to double check through data cleansing. So there's a proportion of women who are carriers who will have a level of between 20 to 40% who by current classification would be considered to have mild haemophilia. And equally then we have had transitional changes with regards to children in the interim between the 2 reports.
So the figures you give in your statement are of 596 people registered with bleeding disorders registered, with 64 people with severe haemophilia A or B, and 3 with type 3 von Willebrand's. Which figures do you think are more accurate?
Those figures will follow from the time that the audit was done, and they were generated from the haemophilia database at that time. So the figures that I've given at the time of my statement trump the figures that were from the audit.
Thank you. If we can move on now to the products that were used and are used within the centre. When you started at the centre, you say in your statement that since 2008, all patients with haemophilia A have been on recombinant factor VIII. Is that right?
That's correct, yes.
And all but one patient with Hemophilia B has been on recombinant factor 9.
That's correct. That patient who had received recombinant factor 9 had not felt personally that it was achieving his bleed control that he had previously experienced with regards to his plasma-derived factor 9, and as such, he chose to return back to the plasma-derived factor 9.
And those with von Willebrand's disease receive either DDAVP or intermediate purity plasma-derived clotting factor.
Yes, that was correct at the time of the statement. The current recombinant von Willebrand factor is now available within the UK market, and we have that in stock now to be used within its licensing for on-demand.
And in terms of current arrangements of obtaining the product, I understand from your statement that all products are tendered and procured through the National Clotting Factor tender process.
That's correct.
What's your role, if any, within that process?
I mean, the role has changed a little bit from whenever I've started to the way that the role is now. I think that at the start, representation provided through Northern Ireland with regards to the tender process or the what was originally sort of volume-based purchasing of factor. So we were able to risk stratify, or I was involved for Northern Ireland's behalf to risk stratify products by a weighting criteria in relation to evidence to support its particular use. So that was quite an intensive thing that was undertaken initially with regards to the procurement, and Scotland, Wales and England had their own representatives involved in that. More laterally then, it's being undertaken as a flat per unit cost that is being managed through the Central Medicines Unit. As a Haemophilia Centre Director, I am kept up to date with regards to the discussions and also with regards to the contract and the wording of it as to how, just to make sure that it meets needs of patients.
When you're discussing with a patient the type of treatment you're going to give them, what information would you give them about the risks and benefits of the type of treatment?
Yeah, I think over the years there have certainly been occasions whereby a recombinant product X will have to change to a recombinant product Y, particularly with regards to haemophilia. The largest switch occurred a number of years ago whenever a product withdrew from the UK market. And as such, we had to have that discussion with the patients. I think what's always important is the reassurance that it's a recombinant product, that we're changing from one to another, and that we are not going back to plasma-derived. So being able to provide them with that reassurance, it always gives us an option to have the discussion with them with regards to second generation factor 8 versus third generation factor 8. Also more laterally gives us the discussion with regards to standard half-life or enhanced half-life, as well as non-factor replacement. So the choice is certainly expanding and has been over the last number of years as to what patients may wish. I think one of the greater risks are always changing, and whether or not the product itself is as effective as what they have been on. And certainly a lot of the discussions with the patients have often come back to ask me, but I'm okay on what I'm doing, I'm not bleeding, and going, but you don't need to change. We're just offering that there are alternatives which may involve less venipuncture or less administration that they would have to go through. There's always a risk or a theoretical risk with regards to inhibitor development, and we always try to make sure that at least that is updated. In more recent publications and reviews, that risk has not been upheld with regards to it, but it is always something that we have to bear in mind in changing. The one that most of the men want to know about is what dose do the vials come in. So I think sometimes with regards to the choice of a particular product, they don't like having to disconnect two syringes to inject through their butterfly, so they do like having a product that comes all in one vial, and so some products are offered through different concentrations that we base that with them. So with regards to it, at any time of changing or any change in contract, all the patients had been written out to, more so with regards to the volume-based purchasing of factor, letting them know what the outcome of the tender had been, reminding them of the product that they were on and whether or not they needed to change. So even the men that we didn't feel would require to change, or there was no need with regards to the tender to change, they were informed, but equally asked whether or not they actually did want to take the opportunity to alter their product. But we go through that on a daily basis with regards to the clinic. Whenever the men come up, we review what they've been taking. We now have HemeTrack in place with regards to tracking what their usage with regards to the factor is, and then we can get a better feel of whether or not doses need to be changed, or even the product or the frequency of injection can be changed.
And when you're dealing with, or when you were dealing with plasma-derived clotting factor for von Willebrand's, what information did you give to patients about potential risks of pathogenic transmission?
So we changed a number of years ago from one product to a second product, largely because an additional barrel inactivation step was introduced into a product, and then it changed its branded name. So from my perspective, the patients had been managed for many years on product X, and they were very well versed and familiar with that. I would, however, always view any patient that I meet for the first time as a new patient, and it would have been my routine practice to explain to them with regards to the product that they would get, that at that time von Willebrand factor is derived from blood donors. It is screened for known pathogens with regards to HIV and hepatitis, and that it is not sourced from UK blood plasma. They're also informed that with regards to the choice and the treatment of it, it is as required, and therefore we will have the balance with the patient with regards to any procedure or surgery that they may be going with, and explaining to them up front what the proposed plan was going to be and following them. It would have been and had been routine practice for those patients receiving any plasma-derived product with regards to vaccination for hepatitis B, and a lot of time would have been spent in checking patients' response to that vaccine and immunity, and explaining that to them why we were doing it because of the risk.
And would you provide any written materials to patients after those sorts of conversations?
It wouldn't have been routine practice, I would have to say, from my perspective, until more laterally, particularly with regards to the enhanced half-life products. I think that whenever we're explaining a factor VIII molecule, albeit recombinant, and then stating that extra proteins are being added onto that factor VIII product, it was much more important for the patients to be able to understand what those proteins were. And a lot of the time would have provided review articles or synopsis with regards to the advantages of using such products. But certainly the insert from the product itself is delivered to all the patients, and that's able to detail any of that additional information.
Would those sorts of discussions also be recorded in patients' notes?
Yes, with regards to product switching, it would be recorded in the notes and reflected in the GP letter. The information would be shared with the blood bank to ensure that if out of hours the patient were to present, to ensure that we're consistent with regards to the brand of the product the patient would receive. And also we would update then the patient's registration card that they carry on themselves with regards to the new product details.
When you're seeing a patient today in clinic at one of those review appointments that you've spoken about, what tests are you doing on a regular basis?
Yeah, so I think the most routine thing is a history and seeing how they are. I think that's the only way that you can actually interpret a test is to know actually how the patient is on the day. Routinely, we will check a full blood count, checking the hemoglobin, the white cells, and the platelet count. Often that can be quite telling, particularly with bleed frequency. Picking up iron deficiency is not an infrequent observation with regards to our patients. We would routinely do liver function tests and kidney function tests, and we would also routinely check their factor VIII level or their factor IX level or their von Willebrand level. And for those patients who are in routine prophylaxis, we would match that to the time that they last took their injection. So that gives us an approximate pharmacokinetic result of the patient. So if they said it was 24 hours ago, I would have a rough idea of what level I should find. And if we find that, then we are reassured with that. For subspecialty types of bloods, in the past for our patients who had had hepatitis C, we would have routinely undertaken an alpha-fetoprotein for those patients, regardless of their history with regards to their hepatitis C, and we would have undertaken that routinely. We can undertake from time to time iron profiles, and for our older gentlemen patients, whenever they're over 50, we would routinely undertake a prostate-specific antigen, and over the years we have, on average, detected about one case of occult prostate cancer in a man with haemophilia annually. So they would tend to be our more common routine bloods, full blood count, renal function, kidney function, and their factor level.
Can you describe for us the consent process that you'd undertake with a patient at a routine appointment for those tests?
Yeah, so whenever the men would come in, my routine practice would be to go through their history, see how things have been going with them. We would pull up on the computer screen bloods and blood results, and to discuss those with them, and to repeat the same test that we would be doing today, or additional ones depending on how they were feeling. As I had earlier said, on a Monday morning we have a multidisciplinary meeting with our laboratory staff, nursing staff, and all of our other allied healthcare professionals. And at that time we go through each individual patient who will be coming to the clinic. We discuss and reflect on their needs in the interim, and also the bloods that they'll be getting checked on that day. So not only would I go through the test that we are doing and to explain why it is that we're doing, and to put them into the trend that we've seen from previous tests, but our nursing team then, whenever the patient goes out, our nursing team then would go through and reiterate the same tests and explain that also to the patients as well.
Have you ever had cause to test for a particular virus, for example, a parvovirus or something similar?
Yes.
And if so, would you have a different consent process, a more formal consent process for something like that?
No, so as my job as a consultant haematologist with a special interest in coagulation, on a routine basis, HIV testing and hepatitis C testing is part of a standard block of tests that are discussed with patients, for example, who may present with a low platelet count. Parvovirus would be not an uncommon test that we would often undertake in our obstetric clinic with regards to women who may be a little bit anemic due to the parvovirus complications. So it's discussed openly. Again, it's been already previously highlighted through our Monday MDT with the nursing team. So the patients are explained, they've come with a problem, we take their history and we reflect on it and take their additional tests and risk factors and discuss it with them. And then they're informed with regards to the test that we would be doing. And if that included an HIV or a hepatitis screen, the patients are informed of that. They are informed that it would be deemed as a routine test for them. As and when the results are back, patients can be informed directly with regards to the results, because often the discussion will cause anxiety despite there being no risk. Patients would be very concerned with it, and then the nursing team as well would repeat the similar conversation. There's no documentation with regards to assigned consent, but with regards to the documentation of the consultation as well as the letter sent out to the GP, there is open declaration with regards to the tests that are done. And currently in Northern Ireland, all of our records are upheld in an electronic care record system, and that is open to any healthcare professional that can go in. And there is a link with regards to all blood tests that have been undertaken serially in any individual patient using their health and care number.
Can I clarify one point there? Are patients informed that the test is going to be undertaken, or is there a discussion that it can be undertaken and they're consented for that? Because your answer suggested that they were simply informed.
Yeah, so no, you're quite right. So with regards to the test, they are discussed and that we would go through them. And if there are any issues or concerns or anything from patient's perspective with regards to what it is that we're testing them for, that they have that opportunity to raise it or to discuss it further.
I understand that the centre no longer stores blood samples on a routine basis, apart from in relation to the genetic testing.
Yes, that's correct.
Have you had any discussions with patients about previously stored samples and whether they were aware of samples being stored historically?
So with regards to the terms of reference of the inquiry and watching the last 2 days, I'm certainly aware of those types of discussions that have been highlighted and come to the fore. And those patients who have submitted their statement have also reflected with myself and the team over that period of time with regards to their observations.
And what have patients been saying to you about their knowledge of stored samples?
Well, as with regards to their statements, I suppose that have been provided that some
Sorry,
had felt.
I'm not meaning the statements. I'm not meaning the statements that the inquiry has received. I'm meaning conversations that you've had with patients.
Okay. most of those conversations in recent times have been with those individuals who have submitted their statements to the inquiry. I think with regards to stored samples, they have reflected on those who have requested their medical notes. So they seem to be the ones who are discussing it more with me and highlighting things with me, and have contacted us in the recent times with regards to storage of their samples historically.
I understand from your statement that all the patients at Belfast had been tested both for HIV and hepatitis C. All the patients with haemophilia and vulnerable brands had been tested for HIV and hepatitis C by the time you arrived at the centre.
Yes.
Do you recall any conversations with, for example, Dr. McNulty or any of the other staff about that time and about how events had been managed in relation to the testing for HIV and hepatitis C?
I think many of the patients had reflected with regards to the epidemic with hepatitis C and E.
We've lost Dr. Benson again. Hopefully he will return.
Conversation.
Sorry, Dr. Benson.
We lost you at the point where you were just talking about the epidemic with hepatitis C.
Yeah.
They'd reflected on that, and then we froze.
Yeah, so the patients themselves have reflected on their lived experience having come through the epidemic and the infection of hepatitis C and HIV. I think I've not had any discussion specifically with any of them with regards to on the specific topic of consent or what they're informed or what they have told. I think their reflections, as with mine, have been more of a pastoral nature in understanding the effects on them rather than the event itself. So
I'm about to move on to a different topic. I wonder if now's a good moment to take a
yes,
break.
I think it probably is. We normally take a break about half an hour in the morning, as you will have seen from the last couple of days. So let's take a break now and come back at 10 to 12.
Thank you.